Hey guys, good afternoon. Happy Friday. Happy test day, right? Or tomorrow or Sunday. All right. I'm gonna need to get everything set up on my end. Signing on. Today's gonna be short and sweet. Okay, lay down. Lay down. Not you. My dog. Lay down. Violet. Hi. You see everybody? Yeah. She's my
Love the side eye.
she's she's resting bitch face. Put it that way. she's, even the vet said something's not wrong with her, but like there's something in there. There's something mental health wise. We actually had that conversation. Some dogs are on Prozac. Did you guys know that? Fun fact. Yeah. They can actually use it for animals. Just actually the same antibiotics. I used to work at a vet when I was in high school, cleaning cages and whatnot, and the amoxicillin, everything was the same. It's kind of interesting how closely related we are. Uh-oh. There we are. Okay, perfect. All right, so you guys are almost all on. Let me just open this up. While we're just kind of all sitting here, does anyone from second semester, we'll start there, have any burning questions? And this is not clinical, so we're not going to make it about clinical because many of you are not in it, so I don't want to take up class time. But does anybody have any burning questions? And I will make a comment about it, about clinical, for those of you who don't have one or are waiting to be placed. I'm kind of now in charge. Oh. I took over. I just told them I'm doing it. So
So if you know that you definitely cannot go to the Stanford clinical, does that mean like for sure you'll probably end up going to the one at the end of the semester that'll run into the summer?
on two things. So there is an instructor, and I don't know how much I'm allowed to reveal. There's kind of a process of onboarding, and she didn't do anything wrong or anything like that. It's more of it was a late hire because you guys know why. We had to hire some extra staff due to a tragedy, and so when she got hired, and I actually know this, I work with this woman who was hired. The paperwork takes so long for the BRN to say yes, she's allowed to teach, she's legit, she's actually a nurse. So it's really waiting on them. So if the plan is still to go to Stanford, we are in. I'm not in contact with Stanford, but Miss or Colleen, I don't know her last name. What's her last name? I call her Colleen. O'Leary. Yes. So it's a 50-50 chance. If the BRN approves her, then you guys will go to Stanford. Stanford is still willing to take you at this point, which is good news. If not, then the plan is for me, and I'm actually, there's a couple reasons why today's a little more short and sweet. Number one, you have a test. Number two, I'll explain kind of what we're doing and why. And then number three, I'm actually going to San Jose Behavioral Health to help them scan and get there's so much to be done, and the quicker we get it done, even if we start a week earlier, I'm like, I'm coming. Can I come in my sweats? And they said yes. So I'm going, and I'm going to be an admin at San Jose Behavioral Health. So you may end up going there. However, it may be maybe earlier than you think, and we can always make it long. It's going to be me, more than likely anyway. So we'll talk as a group at that point if it comes to that point, and we'll do longer days if we want to. No one's there in the summer. So we get a little bit more flexibility if we do that. So yeah, that probably wasn't that was a very long answer, but all the information that I have on Stanford. But the hours, I mean, at this point, I would just, I know it's hard to focus on this, but focusing on I'm going to get the hours, I think that's truly key at this point. It just sucks not knowing and having it up in the air. Now, the others who are not going to Stanford and who are just kind of sitting around waiting, well, not sitting around, doing your stuff and waiting, and when you're going to get to go to San Jose Behavioral Health, that's what I took over. So basically, I think by the end of today, definitely tomorrow, I'll know who's going first. That way you can at least plan your life. So who's going to go the first 4 to 5 weeks, depending on how long your instructor says so. So one of my groups will go and one of Ranjit's will go. And it's all based on who got their paperwork in first. It has nothing else to do with anything else other than that. And I know at this point who those two groups are, but we need a third check of your paperwork to make sure it's all good. And once we get that check mark, then we schedule the orientation, do the orientation, and then we start clinical. So any other quick questions before we get started with our lecture about clinical, since I'm here?
So for group 6, you would be our clinical instructor, or is that going to be somebody else? Like the group that got abandoned?
If you're second semester, I don't have any, oh, do you mean for Stanford?
No, it's for the group that didn't have any clinical instructors for both mental health or med-surg.
More than likely, yes, because I think I'm the only one that volunteered. Not that anyone's bad, just because I just said in the very beginning, I'll do it. That's fine. Whatever. I said, I'll take 20, I'll take 30, just give them to me. We'll have fun. We'll get it done and we'll learn. So yeah, I guess I would get some, I don't have any second semester, so I'm pretty excited about that. Oh, you guys are so cute. Thank you. We're not complaining. Thank you guys. Yeah, I don't know if I said this last week. Maybe I did. But I did I thank you guys just for being so patient and like not, you're just very kind people and very understanding. And I know this is very stressful. So I really appreciate it, on my end, your being able to manage your anxiety. And if you can't, then that's why we're here, right? Call me or whomever, if you're more comfortable with someone else. But as well as all the other instructors, priority is to get you through. I think I'm just a little bit more of a control freak and a little bit more like, now it's a challenge. You're not going to tell me we're not going to finish. We're going to finish our hours. We're doing this. So I'm going to do everything within my power to make sure it happens. And I'm in super close contact with Catherine, who is like the hub of San Jose Behavioral Health, of getting you in. And I made her very, very happy yesterday. So that's good. I won't tell you what I did, but basically I'm working for her for free on the side, helping her with stuff, paperwork. So whatever. That's ethical, right? Oh shoot, we're recording, huh? Okay, whatever. It's for you guys, so whatever. Gotta do what you gotta do. All right, so let's get started. As I mentioned earlier, pretty much we're all on. There's a couple missing, but they're probably just exhausted and sleeping or don't want to hear me talk. So today's short and sweet. You have your test that opens up. You already did your med-surg test. That's done. Did you get your results?
We haven't done our test. She's actually still writing it.
Oh,
I thought it was done. Oh, okay. Well, your test is already written for me.
We have our second test. Yeah, it's like this weekend sometime.
That happened fast, right? Or is that just me?
Yeah, she's kind of like testing every 3 weeks or something.
Oh, okay, so
every 2 weeks of material, I guess.
Okay. We're doing the same thing, except I'm doing quizzes, she's doing tests.
Mm-hmm.
That's a lot. Okay. So we will be, you're going to notice a couple things. So number one, you'll notice some, if you haven't noticed yet, some things are kind of moving around on your assignments and when they're due. And I'm kind of elongated some things because sometimes we don't know how long it's going to take. And when I was done writing the test, I said, well, I want to go over this with them. I personally think it's important to go, that's just me, to like actually go over it, because you might have like a question like, why did I miss it? Don't you think that's important? Why you missed it? Of course, because that's the rationale, right? And actually the NCLEX themselves says that is one of the most important things to do, is to go over why you got it wrong, if you got it wrong, or even if you got it right. So I actually want to go over the whole test, one through, there's actually only 32 questions, by the way. It's 50 points, but it's worth, because some of them have multiple questions in the short answer. So what a concept, right? Exactly. Like, wow. So I elongate. You'll notice some things are going to be moving around, and I'm adding more assignments and stuff this weekend. This is just how I do it. I know not all of you like it. I'm sorry. I kind of do things 3 weeks at a time. It's just the only way I can keep up with the amount of load that I have right now. So you're all doing very well. This is the first time I think ever at this point in the game, especially with newer nurses, everybody has above like a 95%. That's pretty damn good, right? That's really good.
We've been having showdowns with other professors about giving us our test results and questions so that we can see our errors, and a lot of them refuse to do that. So that's why we're all laughing in the comment section.
I didn't even see. Wow. You know why? I'm just gonna tell you why. This is my philosophy. I don't even know anyone else. I don't know any of the other lecturers. Honestly, I think it's because they don't want the argument, or they can't explain why it's right.
It's also because of test integrity. They don't want the questions to get out so that they don't have to redo tests in the future.
Regardless of whether or not it came from a test bank, but that's beside the point.
There's a lot of concerns among the other professors about cheating and the impact of it, and the bottom line is that they don't trust us.
Even so,
which seems kind of like, honestly, to me, it's like a tiny bit, I'm just going to use the word offensive, because it kind of is like we're being trusted on so many other levels, and in this like educational field and everything that we're doing to like get through school, and to not be able to like access our own exams and like review our mistakes because they think we potentially are going to cheat is kind of, sucky.
And just to throw that out there, you shouldn't be using the same test.
Exactly. They want to not have to spend the time generating new test questions for future exams. They just want to recycle
at our expense,
and then deny us the ability to evaluate our test results.
and then they're rude about it too.
And this is venting, by the way. We're not gossiping. We're venting. We're therapeutically communicating. This is okay, because we're not saying so-and-so's a bitch, or this is, we're not mentioning names, but
We really just want to be able to learn from our exam, like what we did right and what we did wrong, so that we can like adjust our studying techniques.
Yeah, or learn, because what if you don't know, and then you're like, well, if I can't even. Wow. Okay. Wow. That's one of my pet peeves, actually.
Expected to be trusted with like people's lives, and we're not even trusted with like our test scores.
And that A, B, you should never. So I have like several different types of tests. So for you guys, I had to actually write the test, because I've never taught this specific course. I've taught other theory courses, of course, but not your specific one from this book and from like our lectures. So I actually wrote our test. I'm not gonna lie, I was really behind. So Miss Amanda threw a fit yesterday at work, by herself. Don't worry, no one saw. And I was just like, I can't do this. And so I basically, okay, I'm not gonna lie, I wrote the test this morning, but I already knew what I wanted to write. So it was already written. I already knew exactly what I wanted to say. I had an outline. I knew what we were doing. So your study guide goes, it's perfectly in line. I'm not worried about it at all. Like I said, there's only 32 questions, just some have. So please do me a favor. This is what I want you to do. When you're reading your questions, and they're the short answer ones, the reason why I do this and I add more than just one question to it and not make more questions to make 50 is because I want you to read the whole directions, because that's how the NCLEX is, right? You don't want to miss something and get it wrong. And many times we tend to do that. And I gave you 150 minutes for 32 questions and 2 days. I think that's plenty of time. I was like 16, 60s, 120. That's like 2 hours. It's way more than enough time for the first test. And the only other test that we have in this class is, I don't even know what, so I'm sorry about the verbiage. On your San Jose State doesn't really do midterms. I didn't find anything that said midterm. I saw something that said final. So I changed the name. It's the same thing. Test, midterm, whatever you want to call that. This is what this is. The only other test it'll be worth 80 points will be at the end. That's your final. Every other week is when we have our quizzes. So that will just continue. It will still continue. I'm still having trouble talking from my fat lip. I apologize. So my S's are not coming out as they should. So there's that. As I had mentioned, 32 questions, 50 points. I grade them pretty quick. I try really, really hard. The assignments, I'm a little slower on, especially the videos. Like I said, I need a day where I'm just sitting and I can really do them. So that might be, I'm hoping this weekend. If not, it might be next weekend. Because again, you spent your time doing it. So I want to spend my time really like watching it. And you're like, please don't watch it. Just hurry up and give me a grade. I don't want you to see what I did. So thank you guys for doing that. I know that wasn't always fun for everyone. And yeah, so what we'll do next week is we'll basically pull up the test. We'll go over it together. That's actually like, we're doing free NCLEX questions, if you will. So I would say I wrote probably half of the questions you've seen before. I wrote probably only like 7 of them, and then the rest are actual NCLEX questions that came from Kaplan. And I wrote in the in your little study guide. That's why the study guide wasn't very long. And then we'll go over them so that you're learning. So the ones that we've gone over and over and over again, I may not go into as much depth. It's the ones we haven't seen before that will go into more depth. Okay, does that sound good? So who knows, that could take 10 minutes or it could take the whole half the class. I don't know. So that's why I elongated it into addiction to make it basically 1.5 classes, half next week, half the week after. And there's like a spring break or something too coming up. So I don't know what that means because I don't get a break. So, okay. Does all of that sound good? I'm reading the comments. You guys are so funny. No questions? Okay. I appreciate you guys too. Thank you so much. Lazy teachers, make more than one test. Jesus. You should have hundreds. You should have hundreds of questions. Hundreds. Right. Anyway, okay. I digress because I won't stop. And this is short and sweet, right? Okay. So
this is so therapeutic. Thank you so much.
You're welcome. I could like see like so much release coming out of people's bodies just watching your body mannerisms. It's like amazing. Okay. So today, all we're doing is we're going to go over one NCLEX question that you have not seen before. Just again, because like I said, I like to do that. We're going to go over what we did last week because I like repetition. And how we're going to do it is the beginning ones, we're not going to, necessarily, I'm probably going to say most of them, but we're going to then focus more on the medication, again, just for the reiteration. And then I have 2 new ones we're introducing. And then that's it. And then I want you to like focus on like your test, like studying and getting ready and all of that. Does that sound good? Okay.
Oh, I have a quick clarifying question. So you said no pharmacology on this test except for the one that would be specifically like name dropped, right?
Exactly. So that one, there's nothing new. If there's any pharmacology, it's something that you've seen before. So that is correct. Yes. So your next quiz will be all pharmacology. And it's only what we've gone over through the Quizlet. And I did correct the word neurotransmitter. So now it's spelled right. I just kept hearing Kurt, sitter. So I was like, oh my God, I have to fix that thing. And like it ran. That's why I was almost late. You really got into me. I was like, no. Okay. Any other questions about the test or anything before we get started? Okay. So let me share. Let's do the NCLEX question first. Okay. Can everyone close their eyes for me? Please, just don't look at the screen. So this is integrity, and I trust you because all of your grades are going to show when I pop this up. I'm trusting you. Don't look until I say please, because I do trust you. I'm still trusting you. It's taking longer than I thought. Give me 1 minute. Okay, you may look. Thank you. See? And I can only see like 4 of you, so I don't know. I know 4 of you didn't look. Okay. So where is it? I hate the way they arrange the screen. It's so not user-friendly. Okay. I don't want you right now. I want you. Okay, there we go. Perfect. Okay. So this is you guys, right? Yeah. Yes. Okay, so one question we're going to go over. Did you guys like the meditation? Did anyone listen to it? It's inappropriate, but tell me it's not hilarious. If you haven't,
It was super funny.
Oh my God, I still listen to it. Every time I pull up the screen and I see it, I have to listen to it. Because it's so true. Sorry if it had offended anyone. I really had to think about it. I'm like, should I put it? Should I put it? Should I put it? And I did it. I'm like, what's the worst that could happen? They can't fire me. They need me. At least for right now. Okay. What week are we on? It's not even close. Here we are. This is today, right? All right. Okay. And I know looking at this, like, oh my God, this is like the easiest question ever. But there's a reason why I picked it. So can everyone see the screen with the question on it? The NCLEX question, yeah? Okay. So a newly admitted, so remember, we always look at time. Newly admitted, maybe that matters, maybe it doesn't. We don't know. A newly admitted client with a history of convulsions. What is another word for convulsions?
Seizures.
Very good. Very good. So tremor, seizure, some sort of not good central nervous activity going on, central nervous system activity going on. So we have a newly admitted client with a history of seizures suddenly says to the LVN, I hear drums. Which of the following should the LVN do first? Okay, so we're going to say, what are we going to do first? Again, we may do more than one of these. We may do a couple of these, but what is the one thing we want to do first? Now, I'm going to dissect this real quick because I think that's important. So let's dissect what this is actually could potentially be asking. So when I look at it, actually, I'm going to ask one of you guys. When you look at it, we know it's a newly admitted person. So that's important because I don't know this person that much. So I don't know much maybe about them. They just got there. It doesn't say exactly when, but it's a new person. I don't know them from from anywhere, basically. And then it says here, the history of convulsions. That is definitely important. If I have a patient that has a history of seizures, I definitely want to know that. And then why might it be important when I hear this, I hear drums? Why would that kind of point out for 2 reasons? Maybe for more.
The patient is having an aura.
Exactly. So they might be having an aura. That's exactly what my first thought would have been. Okay, they might be having an aura because they have a history of having convulsions. What else could, again, we don't know, right? They could be having a hallucination. They could be having, we don't know. But so keep that all in mind.
What's an aura again?
An aura would be something that happens before you have a seizure. So a lot of people will either smell something or they'll kind of see something or hear something, and that indicates to them a seizure is about to come on. And most people that have seizures do, like a seizure, actual epilepsy, they'll know it's coming, so that's why they notice it down, so that they don't fall and hit their head. Thank you for asking that. Okay, perfect. Okay, so what are we going to do first with this client? So number one, tell the patient to ignore the drums. It's a very easy question, but there's a reason I'm doing it. So would we ever tell a patient to ignore? Is that therapeutic? Is that even nice? Would we say that? Please say no. You guys wouldn't say that, right?
No.
Okay. I'm like, I need one no. Was that Robert?
Yes.
Thank you. So no. So I can automatically get rid of this one because I know I would never say that to a patient. Number two, place the client in a darkened room. Now this part right here is not wrong. This would not be wrong if the end of it said, with a staff member monitoring the client. That would not be wrong, because we're putting them in a dim room just in case a seizure could be coming on or something like that, or it doesn't make it wrong. What makes this wrong? What is the key word that makes it wrong?
Away from the nurse.
From the nurse station.
Exactly. Number one, we normally don't ever put, I don't want to ever say never, but we usually never put a brand new patient, especially with a history of something. That's why in like the ICU, it's so small and everyone's together. So the nurse's station is right there. You can watch the patient all the time. We don't want to put this patient, especially, away from the nurse's station when they're saying, I'm hearing drums, I have a history of convulsions, and you barely know the client. You don't know their history. They could have just got there. I would never want to do that. So that makes it wrong right there. But again, if I change the end, I could make it right. So we don't make things up. So we know number two is not right. That is not, because remember, what is the NCLEX about? It's safety. The NCLEX is about safety, period. That's what they want. That's what they say, anyway. Number three. So now we're down to two. That's good, right? Number three. Continue to question the client. What do we think about that?
It's a possibility because it sounds like an assessment.
Exactly. And this is my problem. Okay, my only problem with it, and I'm going to tell you right now, this is the right answer. I just don't like it how it says continue to question the client, because it sounds like you're interrogating them. So I don't like the verbiage that they use, but it's still it's if you look at all of them, watch, we're going to do that. It's the only one that makes sense. Otherwise, the other ones are definitely all wrong. So it's the only one that makes sense, but I wish they would have verbalized it differently. But I think they're trying to probably confuse you. And then number four, insert an oral airway. A lot of, when I say new, I don't mean you kind of new. I mean like brand new LVNs. They love this one. Because ABC, it's got to be an ABC. If ABC is there, is there any indication in this question that says anything that the patient can't breathe? Right? And we wouldn't put this in while the patient, the patient's not even having a seizure anyway. We wouldn't put in an oral airway in that moment anyhow. So this is the main reason I picked this question, is because I really, and I think I've said this before, but I really think it's important to understand that it's not always ABC. ABC is not always going to be the answer. And it may be BAC, it might be CAB. It depends on what they're specifically asking you about, right? If they're asking you about your leg, did I give you that example already, your leg being edematous? Like having a lot of edema bilaterally, you have a patient, I'm just making this up, but I use this as an example. If a patient has bilateral edema, what could you do to help relieve the neuropathy in her legs? Letter A, give prescribed diuretics to patient and gabapentin. Number two insert an oral airway, or number 3, tell her to deal with the pain. Obviously, we know it's not that one. The first one, even so, they're both ABCs, right? Because circulation is edema. But what's airways supposed to be first, right? All the time, all the time, all the time. But in this circumstance, that's not what the question's asking us. So that, I know this probably sounds like dumb, Miss Amanda, but it does happen because sometimes the questions are they get more complicated, and it's like, well, what are they really asking me? And if you don't know what they're asking you, it's not going to be as simple as, well, of course it's edema. I'm not going to put an oral airway in. They can breathe. I'm going to give them diuretics to help pee out some of that or void out some of that fluid, and give them their gabapentin to help with their neuropathy because they're in pain. So making sure that you really understand that is really important. Is anyone brave enough to say, did they pick this one?
I picked number 3, but I looked it up after I submitted, and it said that the answers are the oral airway on like the Quizlets.
No, it's not. I promise. I teach this in Kaplan. It's not the answer, I promise. That's not my right hand. This is. No. Because why would we?
I know, that's why I was confused when I checked the answer afterwards. All of the Quizlets that, or like the 2 quizzes I looked up, the answer says insert the oral airway.
By the way, students make those, and that's not my Quizlet. So they're wrong. Whoever made that Quizlet is wrong. You guys get that, right? Like, people make
I have a clarifying question about 4. Is that referring to like intubating someone?
You tell me.
Because when I see like insert an oral airway, I would assume like they're talking about an intubation, and that's not even within the scope of practice for us, right?
It could also just be the little plastic OPA, like that little green one. I think we've seen it maybe like once, that little plastic one that you put in.
So that's exactly why I asked that question. So first of all, they don't clarify what type of oral airway. So we don't even know what type of oral airway. When I think of it, I thought exactly what you said about the little, I don't know what it's called, that little thing.
Oh, pharyngeal airway.
Exactly. So that's what I think of, but they don't even say which one to put in. Are they saying intubate, or what do they? They're not giving me any more information. So, and you are right about scope of practice. So it's definitely not inserting an oral airway for many, many, many reasons, and I could argue that one all day, but really there's no indication. That would be like me right now, like running over and like intubating Claire. Like, Claire's breathing. I can see her eyes. I could see her mouth earlier. I see, oh, there she is. She's moving. She looks like she's breathing. Everything looks good. That would make no sense then, right? I would just be, actually, what would that be called? We just learned this. Is it
battery?
Battery.
Yeah, I'd be battering you. Exactly. So we would not do that. So the only one that really makes sense is going to be continuing to question the client, because again, this is not therapeutic. Putting them away from the nurse's station is not safe. There's no indication of putting in an oral airway. And then continuing to question the client is assessment, which is part of nursing process. And that's going to give me more information about the client. And can somebody that has not talked yet tell me maybe something therapeutic that they would ask the client? I mean, very, very simple about if they gave you this scenario, what would you say to them? What would maybe your next question be?
I think I would ask if they've experienced that before.
Lovely. That's lovely. And that could actually be a yes, no question and an open-ended question. And it doesn't always have to be open-ended, but exactly. Has this happened before? Beautiful. Because what's that going to tell me? If the patient says, yes, this has happened before, and then they may say, they probably tell you right before a seizure usually happens, and then we can prepare for it. Or if they say no, and then maybe I just found out has nothing to do with the seizures, because remember, what do they say on Grey's Anatomy? If you hear hoofs, it's not always zebras or something like that. So we don't want to always, what I mean by that is assume. So just because they have seizures, we don't want to assume it's an aura. It could be. So we want to keep that within our range of like our brain, and like this might happen. However, now I'm looking in the file and I see, oh, okay, they have schizoaffective disorder or with, oh, okay, they have auditory hallucinations where they hear music. I don't know. So you never know. But how are you gonna not? You're not gonna know if you don't do assessment or ask and look at the chart. So as we say in Kaplan, the credited answer, you can't say correct, we have to say credited, is, you can tell I just taught a class. I just taught one for them, so now I'm all flexed out. So continue to question the client. Does anyone want to fight about it?
Hey Amanda.
Oh.
No, I'm not gonna fight about it. I just wanted to read the rationale that it said on Quizlet.
Yeah, I thought you meant because you couldn't hear me.
No. I also agree with the questioning, but on Quizlet it says the airway. So if you insert an oral airway, it prevents the client from biting their cheek or tongue during a seizure. So if they're basically saying like if they're going to have a seizure and you're expecting it to come, you don't want them to like bite their cheek or airway. Like you're expecting a seizure to come.
But even if someone was about to have a seizure, you wouldn't do that.
Or at least you wouldn't do it first.
Right. I just want to laugh. That's all I want to do. Only because it's just like, it's almost like, you know, when you understand something almost so too much where you can't even explain it. Does that make sense? Like, I don't even know how to explain it. How we always assess first. There's no indication here. I would want to ask a question before I really like put yourself. Okay, I'm sorry.
Let's just do a reality check. You're the nurse. Someone says, I hear drums. You pick up an oral airway and insert it immediately? No one would do that.
Kurt, you're ruining my thing. That's exactly okay. Let's just imagine you're at the nurse's station and that really happens. Kurt walks up, says this, and I'm like, you know, whatever over the loudspeaker, need an oral airway. I mean, would we do that? Sorry, I'm like you've never seen it happen. It only happens in checkoffs. I'm the worst. I get the giggles and I will literally not stop laughing. I had a student yesterday ask somebody, what did they say? They were trying to find this poor guy. So he was really shy, or he is very, very shy. And of course he had like a female as his, or woman, whatever you like to be called, as his partner, which is fine. But, you know, they're brand new, just learning to touch each other and all of that. And she was very large breasted. Is that a word? But she was busty. And she had very large breasts. And I'm like, oh, shit. I'm like, oh, my God, because the apical pulse is coming. Now, because it's physical assessment. And I'm just like, oh, God, oh, God, oh, God. And I could feel I was going to start laughing. And I'm like, I can't do that, you know. And so I didn't, thank God. But it was, you know, you have to lift things and move things around. And normally someone's laying down, but we didn't have a bed available. So I had her sitting up. And it was just, anyway. I just said, where, just tell me where it is. And then I had him do it like this, just on top. Anyway, oh my God. It's just so funny to watch them. They're so cute. They're so nervous. I just love them. I love you guys too, but they're just so brand new, you know? I wish I could have you come watch them. It'd be fun. See, if COVID wasn't happening, I could make that an assignment. You guys could come like guest speak or something, right? That'd be fun. Okay.
Honestly, given how clinical went last semester, if you do end up having some of us for your clinical session, it'll probably be the same thing.
Oh, yeah, right? Is that good? That's good, right? Yeah. You don't know. Wait, I have you. Who? Someone has a Ann Nguyen. Is it in our class, right?
Yeah, that's me.
I'm the one that emailed you, and I'm like, is this you? Because, okay, you had me so confused because there were so many extra letters in your name that weren't, okay.
Wait, you haven't emailed me. What?
She emailed me because my middle name's long.
Okay, see, that's why. I knew it. Okay, good. So you may be going to clinical soon. Just saying, your group may have won. I'll text you guys later. Don't worry. Okay, let's continue. You guys are just chatting it up today. LOL, Dr. B. Never trust the internet. You guys are so funny. Okay. All right, well, what I was going to do is I was going to pull up all your names and put you guys on. Okay, so we're going to do the trust exercise again. Close your eyes. Sorry, so the only way I can pull up your names is to look at the grades. And then I'm going to cover them. Okay, now open. I know you can still see grades, but the only ones you can see are all, oh no, shit. Close your eyes again. I was going to say the only ones you can see are all 10s, but there's one. It's not. Close your eyes. It's like when you're a kid. It's fun. Keep them closed. Let me get my shit together. Which we all know takes like 8 hours. Should soon. I'll do that. I'll move back away. I want to do this. Oh, forget it. Just open your eyes. I wish I could like know all of your names, or like, why don't your names show at the bottom anymore? Does anyone know? Kurt, open your eyes.
You may need to change your settings in Zoom.
Okay, that makes sense. Because some classes I can do it, and sometimes some classes I can't.
Yeah, especially if you use a different account for San Jose State versus for another institution, your settings might not transfer over from one account to the other.
Okay, that's a really good point. Now I'm not going to remember that and forget and then not do it. I'm like, can you come over and set up my new MacBook that I can't get the internet to work? It's just ridiculous. Okay, that was Duncan, right? That voice?
Yeah, that's me.
Yeah, I know some of you by voice. What does that mean? They probably talk a little bit more. That's good, right? So then I can pick on you. Okay. So what we're going to do is, I don't want to be the one talking. So we're just going through these. And once we're done with this, we're done. And then there's 2 more medications on here. So normally what I do is I say, like in my clinical, I have 7. And we do it online. And then I assign everyone a number. And if you don't know, all you do is just say pass. It's fine. You just say pass and it goes to the next person. If you don't know it, you say pass, whatever. So we're just going through basic stuff. We're not going to do these ones all the time, but I want to do it one more time. So the only thing okay, because your order is different than mine, which makes it hard. And I want to like pick on you because I'm mean. Like, how can we do this? I don't want to say like yellow sweater. Sorry. I know you were on the balcony last week. Do you guys mind if I do that? Is that rude?
You can also just have us say like the name of the next person.
Okay, so because you guys can see. Okay, let's do that. So we'll start with, and I should know your name, and I want to call you Claire, and you're not. You're wearing the green shirt, and you do participate a lot.
Carolyn.
Here, thank you. So Carolyn, to me, is first. So she's not first to you guys? Okay, so I'm just going to have you go in order. I'm going to trust you, which means that not all of you are going to get picked. So whoever's first, can you tell me, and we talked last week, I had one, you could use one word, just what is a neurotransmitter? What does it do in the brain?
It's like a chemical messenger. I don't remember there was one like exact word.
That's okay. That's perfectly fine because I'm going to tell you what it is right now unless the person... Communicate. So communicate. It helps your brain communicate. Perfect. Good job, both of you. Excellent. The next one, off-label.
Do you want me to say the next person?
Yeah. Yes.
The person next to me is on.
Off-label, it just means like a use for the medication that it wasn't originally intended for.
Beautiful. Excellent job. And then for the next person, can you please tell me true or false? Several psychiatric medications actually are used off-label?
Kurt's next to me, so.
That is so true.
That I love it. That's so true, dude. Yeah, it is. Okay. Perfect. And it's very true. Okay, so now controlled medications versus not controlled or scheduled medications have the potential to be addictive. Who's next after Kurt? Potential.
How about when like a person answers, like when they're done answering, they just say the person next to them so we can automatically just go.
Yeah, I thought that's what we're doing.
I think Nagana was next to me.
True.
That is true. Or if you guys want, you can just pick someone. If you want to be not mean, but you can just pick whoever you want. I don't care how you do it. So perfect. So that is true. So if something is controlled, remember scheduled 1 through 5, which we will talk more about, not today, but if it's scheduled or controlled, and can Claire pick somebody to give me an example of something that is considered a controlled medication?
Morphine?
Or yeah,
Me?
Claire can answer.
Oh, was I supposed to pick somebody?
Yeah, but that's okay. You answered. You're good.
So
Sorry.
you want me to just pick people? I can do that.
Whatever you want. Just pick person. Okay, so now Claire, you're gonna pick the next person to tell me.
All right. Crystal.
So Crystal, can you tell me, does a medication like morphine, which is a controlled substance, need to be prescribed by a physician, an MP, or a PA or someone, or can you buy it over the counter?
Yeah, you need a prescription.
Good job. Excellent. True or false? I'm going to say this one. True or false? Do controlled substances have the potential to be addictive? Yes, they do. Potential. I'm going to keep saying that. All right. So now Crystal is going to pick the next person.
Andrea.
Do controlled substances need to be prescribed in the U.S.?
Yes, they need to be prescribed.
And can Crystal pick somebody to tell me an example of a medication that is not controlled but still needs to be prescribed?
Robert.
Let's go with propranolol.
Good job. Excellent. And then I'm just going to ask Robert because this is super easy. Then you're just there. So Robert, can you tell me a medication that it does not need to be prescribed and is over the counter? Anything.
Tylenol.
Perfect. Exactly. So remember, we have the 3 categories, right? Or not categories, but 3 little kind of clumps. We have our controlled substances that have the potential to be addictive, that have to be prescribed. Then we have other medications that do not give you the dopamine that goes into the reward pathway, which we will talk more about with addiction. So technically, they don't have the potential to be habit forming, but we will talk more about that. Don't worry, because anything can be abused. Like I said, I can snort Benadryl and get high off of it a little bit, but I'll explain what the difference is. And like Robert said, I love that example, propranolol. And then we have over-the-counter medication, which here in the United States is different from somewhere else, right? Because I believe in Mexico, you can buy codeine over the counter, if I'm not mistaken. I could be wrong, but that's what I was told. I don't travel. I don't have time, that's why, not because I don't want to. Okay, good job. Okay, so Robert, pick somebody else.
Next up is Jasmine with a Z.
Jasmine with a Z. What is the difference other than price of a brand and generic medication? This is a hard question. If you don't remember it, you can pass, or if you remember it.
It's the inactive substances, right?
Yeah. Good job. Exactly. This is a hard question because it's something we don't usually talk about very much. So remember, the inactive ingredients are different than the active ingredients. So that's the main difference chemologically. Any questions about that? Good job. All right, and Jasmine with a Z, can you pick someone?
Emily Schultz.
Right. Where is 90% of your serotonin?
In your gut.
Very good. And can you tell me true or false is whatever I'm just gonna say. So that's obviously why if we take something with serotonin, it's activating that as well. And that's usually why we have GI upset in the beginning of taking something that activates serotonin, right? Everyone agree with that? And some people don't. It just depends on the person. And some people will never tolerate it, and then they can't take anything with serotonin in it. Most can, and their bodies will just adapt to it, and some won't. It just depends. Pick someone, please.
Krista.
Thank you. True or false? Oh, that's way not spelled right. Neurotransmitters are responsible for multiple jobs depending on where they are working in the brain. True or false?
True.
Good job. Excellent. And pick someone, please.
Jeff Lynn.
Thank you. What book do we use to diagnose psychiatric disorders?
DSM-5.
Excellent. And can you pick someone, please?
Ivana.
Okay, so how many hours or days is a 5150?
72 hours.
Thank you. And can you pick someone?
Anmol.
Can you give me one reason why someone would be put on a 5150?
If they are a danger to themselves.
And can you give me one more?
Danger to others.
And you're looking at something, so give me the last one.
I'm not sure what the last one is.
Okay, darn it. I thought you had it written down. Okay, pick someone.
Melanie.
The last one's always the one ever. It's always the hardest one to remember.
Danger to others and
danger to others, danger to self, danger to others, or starts with the G.
Gravely disabled.
Yes, gravely disabled. And can you pick someone?
Andrea.
And what does gravely disabled mean? Very simplistic terms. And you can always pass.
If they're like intoxicated or they can't take care of themselves.
Right there. Can't take care of themselves. Very good. That's exactly right. Very good. And pick somebody, please.
Steph.
Okay, so how long can a 5250 go up to?
Up to 2 weeks.
Exactly. Does it have to go up to 2 weeks?
No, it doesn't.
And is it in addition to a 5150 or combined with the 5150?
It's on top of the 72-hour hold.
Oh God, you guys are so smart. Very good. And I'm going to do a couple of these because I promised it was going to be short and sweet. If that's okay with everyone. We're still having participation. So conserved, I think everyone knows what that means, and that has to do with somebody not being able to make correct or safe decisions for themselves. So it's done through a court of law that somebody else is deemed to make your decisions for you. And that usually is in the elderly population or mental health. The fruit that interacts most likely with medications is grapefruit, and it will either speed up the process of the metabolism of the medication or slow it down. So that's usually why on the side of the medication bottle it will say no grapefruit juice or grapefruit. I've never seen a reaction, by the way. I think you really have to have a lot, but that's just my opinion or my interaction. True or false? If a medication creates a release of dopamine in the reward center in the brain, then it has the potential to be addictive. Yes. So dopamine and the reward pathway has to do with addiction. Keep that in your brain because that's going to be super helpful when we talk about addiction next week. And I'm going to be so hyper. So just warning you now, bring your energy because I'm going to be very excited. True or false? Depression and anxiety are often associated with one another. That is true. Name 4 symptoms of someone that might have somatic symptoms of anxiety. Upset stomach, sweating, tremors, headache, muscle aches, cramps, diarrhea. What does OCD stand for? Obsessive compulsive disorder. Just a reminder, you don't have to have both. You can have just obsessions or just compulsions, not just, but you know what I mean. One or the other, or you can have both. Many people don't know that it actually can be split and you can have one or the other. You don't have to have both, but many people do unfortunately have both. Obviously I didn't fix all the typos. In the most simple terms, how do beta blockers lower blood pressure?
It lowers the heart.
Thank you. I know what it is. I just couldn't get it out. It lowers the heart rate, therefore lowering the blood pressure. Thank you. Sorry. Let me just look at one thing. I'm so sorry. I have a delivery that I have to sign for. It's from the State Board of Nursing. I'm not in trouble, don't worry. But I have to sign for it, and they're supposed to be here anytime. So just want to double check to make sure everything's okay. All right. Agoraphobia. Fear. Basically, fear is what I think of always first. And then the next thing that I would like to know would be an example. That'd be fear to leave your house or fear of big spaces. Those are usually how I think about it. What is the hormone in the brain that is released to help to regulate sleep and wakefulness? And that is melatonin. And melatonin, I didn't say this last week. Oh, they are here. I'm so sorry, you guys. I'm so sorry. I'm here at the gate. Pound 8548. Is it weird that the UPS guy has my phone number? That's how many packages I get. Is that a problem? Okay. All right. So the hormone, one thing I may not have mentioned is that melatonin is actually released more so as it gets dark. And its peak is usually around between 12 midnight and 2 a.m. So that's why it's so hard. I mean, I know you guys know this when you go from knock shift to day shift or whatnot, and you're flipping back and forth, and oh my God, you're just all dysregulated. So as it gets dark, usually that's when this hormone is released. That's when it starts to be released.
When did you say the peak was?
Midnight and 2 a.m. Thank you. Medication frustration, just a reminder that it's hard with psych meds. It can take a long time to get that diagnosis, to get a medication that works for that person, and something that they can actually tolerate. Something may actually work beautifully, but they can't tolerate it because it makes them not feel good. So it can be really, really frustrating. So to be empathetic. Okay, so psychosis is, and now someone else is going to, forget it, I'll do this one. No, someone's going to answer it. So psychosis is a detachment from what?
Reality.
Yes. Okay, I love my hand gestures. Okay. All right, an SSRI. All right, so whoever was the last person, pick somebody.
Chai.
Okay, so SSRI stands for selective serotonin reuptake inhibitor. Now, what neurotransmitter is an SSRI working on?
Serotonin.
Excellent, thank you. And you pick someone, please.
Yeah.
Thank you. And then we have SNRI, which is selective serotonin norepinephrine reuptake inhibitor. And what 2 neurotransmitters does that interact with? That type of medication.
Is it norepinephrine and epinephrine?
So close. So say what Cheyenne, right? That's how you say it.
Cheyenne.
Cheyenne. Thank you. I'm sorry. I know how it's spelled, so I actually do know your name. So say the one that he said, and then say one of the ones you said, and you'll get it right.
Serotonin and norepinephrine.
Excellent. So SSNRI is serotonin and norepinephrine. Those are the two neurotransmitters that are being interacted with, or hopefully activated and working. We'll get there. True or false? The frontal lobe is responsible for judgment, impulsivity, and making good decisions. That is true. That's very important to understand, especially when we're talking about addiction. So make sure that you, and again, we're not psychiatrists. I'm not making you any sort of specialist, so we're keeping it simple. Affect is this. Was it you guys that we did this and you were like, so this, you go like this? No, it wasn't. Oh, well, I think it was my other kids. So when I go like this, I just mean affect is your, oh, it was my, oh, I almost said my crazy people. Sorry. My patients at El Camino, they're hysterical. Oh no, it was your classmates that are at El Camino. They're so funny. So affect, because I was going like this, they thought that's what it meant. Because I didn't, I guess, explain it well enough. So you guys understand when I do this, I just mean facial expressions. Okay, just want to make sure. They're so funny. Okay, medications that interact with serotonin often cause GI upset for a week or so. Why is this common? We already talked about that. Because 90% of our serotonin is in our gut. So medication madness. All right. So now go ahead and pick somebody.
I pick Raisa.
All right. So Benadryl, what is the actual classification of Benadryl?
Is it an antihistamine?
Yeah, yes, it is. No, you're fine. Don't worry about it. So yes, it is an antihistamine, and I just forgot they're gonna want my ID when they get the package. So we're gonna take just 5 minutes, okay? Because I don't have my real ID, I have my old ID, and I have to get 2 forms now because, long story, I lost my license. No, I wasn't partying. Not fun. So I'm gonna stop the recording. Let's take 5 minutes so I can get it because my mail area is a disaster, and that's where my ID is. 5 minutes. So we'll be back, come back at 2:40, and then we'll wrap up. All right. Thank you, guys. Okay, so we'll go ahead and get started. I don't think I paused the recording. Sorry about that, guys. So you're gonna hear me like going crazy looking for my ID when you watch the video, if you watch this one, because I couldn't find it. So we'll just continue. So we went with Benadryl. We found out that it was an antihistamine. And just a reminder, Benadryl can be used off-label. And what can we use Benadryl off-label for? Who's the next person?
Can be used for sleep.
Exactly. We can use it for sleep. Beautiful. Very good. All right. Then we have Tylenol. So Tylenol, what's the other name for Tylenol? And that would just be the next person.
Acetaminophen.
Exactly. Acetaminophen. Very good. What's the max daily dose of acetaminophen per day?
4,000 milligrams.
Excellent. And can the next person tell me that in grams?
Brian?
4.
Thank you. And because that was an easy question, where's the liver located?
Like the upper right quadrant.
Like, or is it?
I think it is.
Messing with you. It is in the upper right-hand quadrant. Exactly. So your liver is located in your upper right-hand quadrant. And can Tylenol be tough on your liver?
Yes.
Very good. Excellent job. So we have Prozac, Lexapro, and Zoloft. So those 3 medications, this will be for the next person. Are those an SSRI or an SSNRI?
Jasmine, Balladat.
SSRI.
Exactly. Perfect. So these 3 medications are SSRIs. There are plenty more, but these are the ones, just to go off of. And so SSRIs, if they are working correctly and they're working on serotonin, we've already established that, and they are working appropriately, what should we feel? The next person?
Brian. Calm.
Calm. Well-being, maybe?
Yes.
Like that word? You can make up your own word. I just love that word. I think that's like the best. I just love it.
Well-being.
Thank you. He's like, I said it. Okay, perfect. I spelled Effexor wrong too. Okay, so next person, Cymbalta, Effexor, and Persique. What are the 4 letters for that?
SNRI.
Perfect. So now the next person, Prozac, Lexapro, and Zoloft are classified as anti-what? Antidepressants, exactly. Specifically known as this specific type is an SSRI, and we've established that. Now the next person, Cymbalta, Effexor, and Persique are
Depressants.
Exactly. Thank you. But specifically, they are what?
SNRIs.
Beautiful. And what 2 neurotransmitters do they touch?
Serotonin and norepinephrine.
Perfect. And when I'm questioning, you don't, if you want to keep answering, because I don't know, the voices all sound the same now. It can go to the next person if you wanted to. And then if it's working properly, what should you feel as far as the norepinephrine? 2 things.
Energy and motivation.
You guys aren't even looking at notes unless they're taped on your computer. Good job. Okay, Wellbutrin is an
Depressant.
Exactly. And next person, what neurotransmitter does it interact with?
Norepinephrine.
Yes, we both said it at the exact same time. Exactly. Well, Wellbutrin goes to norepinephrine. We already talked about energy and motivation. For this medication, also can be labeled under Zyban. And when it's labeled under Zyban, what can that help with for cessation-wise? That's could be a potentially bad habit for one's body.
Smoking.
Smoking, exactly. So it can help with smoking cessation. And then what's one other thing if a patient came in and told you that serotonin, they were having trouble with serotonin for a certain reason? For men, actually it's for both men and women. Lack of, this would be a medication we would go to first, would be Wellbutrin if you had lack of what?
Sex drive?
Sex drive, yes. Perfect. Good job. Okay, next person. So gabapentin is an anti.
Convulsant.
Beautiful. Can it be used off label?
Yes.
And same person, can you give me one reason why or how?
It can be used for anxiety.
Beautiful. Next person, give me a reason.
Neuropathy.
And next person, give me one reason.
Sleep.
And sleep. And next person, what's the max daily dose of gabapentin?
400 milligrams.
So add an extra 0.
4,000 milligrams.
It feels like Vernell. You're not Vernell.
I'm
Are you?
Vernell.
Are you really?
Yeah.
You've answered like multiple questions though, right?
Sure.
No, I just want to make sure I'm not like losing my mind because I've seen your mouth moving a lot and you're giving answers. You guys are messing with me. I know. I'm not even gonna. I know what's happening. Okay, propranolol. Next person. What is the classification? Anti.
Hypertensive.
Perfect. Specifically, what kind? The LOLs are what?
Beta blocker.
And how does it lower the blood pressure?
Lowers the heart rate.
Beautiful. And can we use it off label? Yes. And what can we use it off label for?
Anxiety.
Beautiful. Good job. Benzodiazepines. This is remember the umbrella. It's an umbrella and there's several underneath. So can someone, whoever's next, name one for me? There's a ton.
Ativan.
Ativan. Okay, next person, name one.
Azepam.
Yep. Next one.
Valium.
Right. So Ativan, Klonopin, Xanax, Valium, Librium, temazepam, oxazepam. There's a lot of them. And we talked last week, I believe, about the A and the V, right? So can that person, next person, tell me, is A a short-acting benzo? Yes or no?
Yes.
Yes.
And then V, is that long or short-acting?
Long acting.
Right. And that would be Valium. And that's how we remember it. Beautiful. Good job. And can the next person, can this medication be potentially habit forming? And again, if you're on it, that doesn't mean that you're a bad person. I have to make sure to always say that.
Yes.
Yes, it can potentially be habit forming. Doesn't mean it's a bad medication. Next person, antabuse. Can you tell me anything about it?
It makes you get alcohol poisoning so you can stop drinking.
Good job, Claire. It's not weird because weren't you the person I used as an example? Remember?
That was Yuki.
Oh, sorry. Oh God. I try. Where usually Claire's like right on my screen. I miss her face. Where are you? God, I wish we could do this in person. Okay, yes, that's absolutely right. So antabuse is basically, and it's called an aversion type therapy, medication therapy. So it blocks the liver from being able to metabolize alcohol, therefore causing you to have alcohol poisoning. Can the next person tell me how long it lasts in your system? Even though you take it once a day, it lasts how long? Even if you stop taking it?
1 to 2 weeks.
Got it. Perfect. All right. So did we talk about trazodone last week? 40, 41.
Yes.
We did? Okay. Oh, we did. Yes. Okay. So, and then the next two are the new ones, and then we're done. So trazodone is an anti what? This is a hard one.
Antidepressant.
Exactly. Very good. Antidepressant. But do we use it as an antidepressant anymore? I've not seen it ever use it. I mean, and so I don't want to say ever, but I've never ever seen it used because people fall asleep. Because what do we use it for?
Sedative.
We use it for sleep, sedative sleep, exactly. So how many milligrams would you need to use to get serotonin involved? How many milligrams?
400 to 600.
Exactly, 400 to 600. And then for sleep, just average use for milligrams.
50 to 250 milligrams.
Yeah, exactly. That doesn't mean if someone's taking 25, they're wrong or bad. That's just, I'm just giving you an estimate for to kind of clarify that serotonin is not being touched at that level. So it has nothing to do with depression at that point. And what's kind of like that funny thing that can happen, but I've never seen happen, and this is to men. So I guess it's not really funny, but
Priapism.
Priapism. And what's priapism, Vernell?
Spontaneous
Roll
erections.
Erections.
What's the word for it?
So priapism. Don't ask me to spell it. Priapism. It's kind of like when somebody takes Viagra and they have an erection that won't go down and you have to go to the emergency room. That's one weird side effect that I've never seen happen. Like I said, I think maybe probably 1 or 2 people had it happen. Who knows in the study. So they have to do, tell the patient as a side effect if this does happen. But that's not going to be the first thing I tell my patient, because this is a freaking awesome medication. And it's such a rare thing that could happen. And yes, it does suck if it happens, because you have to go to the hospital and have a big needle stuck in your penis, and that doesn't sound like a good time. Ow. I mean, I don't have one, but I can imagine that would not feel good. And can I just share something really quick? I had a student ask me, so we did this the other day at my mission class. This was a medication. You know what she asked? She asked a really good critical thinking question. Now think about it. She said, well, what if they just continued to have sex? Would the erection go down? And I was like, I had to really, really think about it. And I'm like, well, no, because it's 2 different things, right? Or would it? Because blood flow, I was like, I don't know, but I've never seen that happen before. Like with Viagra, for example. If somebody were using it, if they continue to have sexual intercourse, right? And if it doesn't, yeah, anyway, I don't know. I thought it's a good question, right? Someone want to test that out? Let me know. Anyone? Volunteer? Extra credit? Just kidding. Camera, we're just kidding. We're just having fun. Okay, so now I'm going to introduce you to, it's basically 2 medications, but well, technically 3, but I put Ambien and Lunesta together. So Ambien and Lunesta, does anybody know what type of medication this is used for?
Sleep.
Mm-hmm. So it's used for insomnia. The reason I put them together is because they're pretty much the same thing. They're not the same thing. They're 2 completely different manufacturers, all of that, but they're both sedative hypnotics. That's what they're called. Sedative hypnotics. I'm sure you've all seen the commercials for them. You've heard about them. Maybe you've tried them. Like benzodiazepines, they're not meant to be used every day. Ambien is more meant to be like, hey, I'm going to go to Europe, or hey, I'm having a really bad crisis time, I'm going through something really rough, or I'm on the psychiatric unit because I've just gone through a crisis. I need sleep right now. They may use it. Again, it's supposed to be short term. And why is it supposed to be short term? Because Ambien and Lunesta have the potential to be habit forming. Potential doesn't mean that if and I want to be very clear. If you're one of the 50 something people on here that takes it every night, I'm not saying you shouldn't do that. You should stop doing it. I'm not saying you're a bad person or you're an addict or any of that. I want to make that 100% clear.
Where my keys are?
What? Oh, you're not talking to me. Okay. Or were you? Was someone talking to me? My whole point of it is that there's such a plethora of other medications that we can use. In my personal opinion, why go here first? That's just what I feel. Now, if this is something that works so well and you have such bad insomnia, and it really does get you good sleep and everything's fine and you don't have a history of addiction, that's usually where it gets a little bit tricky. We want to be really careful because we don't want to ignite dopamine in the reward pathway. And we'll talk again way more about this and why it can have that potential for a relapse. Not usually as much with something like this, but it's still, I think it's important to know the risk. And we'll talk more about that. So today, what I wanted you to get away from it is that Ambien and Lunesta are a controlled substance, right? Because I just said it has a potential to be habit forming, and it's not over the counter. So it must be prescribed. It's a sedative hypnotic, and they have the potential to be habit forming. They go to the same place in the brain as alcohol, basically. They're like the cousin to benzodiazepines. They're Schedule 4, just like benzodiazepines. And if you don't know what that means, you will. All right.
So where do they go in the brain?
Basically to the same place as alcohol.
Which is?
It's in the next lecture.
Okay, never mind. It's cool.
Sorry. Oh, but I'll tell you. Well, I just don't want to go off on a tangent because once I start talking.
No, it's fine. It's fine. Yeah, we're so close.
Shut up. Stop. We are so close. Oh, that's what she said. Okay, Sarah Quell. All right. You guys ready? Does anyone know what this is? It's an
psychotic.
Very good. Antipsychotic. Can it be used off-label?
I'm gonna guess yes.
It can be, yes. And one very, very common thing that we use this off-label for is, what am I doing? Sleeping. Yes, sleep. So it can be used for other, so Seroquel is not, just because it's an antipsychotic doesn't mean that we don't use it for other things. We use it for bipolar disorder. We use it for a bunch of different things. But I would say two of the main things we use it for, again, to keep it simple, is, of course, it's an antipsychotic. So if somebody is psychotic, and so what does it do in the brain? What does it lower if it's at a certain therapeutic dose? So for sleep, it doesn't do anything with dopamine. Well, I just told you the freaking answer, but it doesn't do anything with dopamine because we're giving such a low level. So I actually take this for sleep. I take 12.5 milligrams, which is like a baby dose, but I have such bad insomnia. I because my mind, I just can't stop. And then it's supposed to go over to the next day and kind of keep you calm. Obviously that doesn't work for me. So what else? What is it doing if I'm giving it to you for schizophrenia at the level that I would give it to you for at schizophrenia, which is, I don't even want to give you a dose. It's a lot. And I don't think the dose is important. What does it do in your brain to the dopamine? Does it increase it or lower it?
Lowers.
It lowers it, exactly, because when you have schizophrenia, you have too much dopamine, right? So if I'm giving you this as an antipsychotic, because you're psychotic, I'm lowering your dopamine. I'm giving it to you for sleep. I'm not giving you enough that's going to affect your dopamine because I don't want to make you sad, right? Because maybe your dopamine's just normal level because I'm not psychotic, so it's not up here. Does that make sense? So I'm at my normal baseline. I don't want to make my dopamine go down if I don't need it to. I'm just getting I call it the byproduct effect of it, which is just, it makes you tired. Now, somebody that has schizophrenia, it doesn't make them tired because they have so much, we talk about in more with mania, but they have so much. It does kind of sedate them, and unfortunately it does affect the affect, and that's one of the downfalls and why we don't usually use this one. This is more old school. We don't use it as much. We use more like Abilify, just as a side note. But I think it's an important med because you're going to see this on the floor for sleep a lot.
So does this have the potential to make a patient like experience Parkinsonian?
Yep.
Okay, thank you.
You're absolutely 100% correct. Hey, if you got half the word right, you know what you're doing. Nope, you're correct. That's perfect. You guys are remembering. Okay, so we're done. It's 3 o'clock. I kept my word or whatever I said. Your test opens up at 4:15. Do you want me to open it early?
Yes.
Okay. I'll open it as soon as we sign off. I'll start downloading this video. Not that you need it, but I just feel like let's keep it. I like things to be the same way every time if possible. I don't have any sort of problem, I swear. A-type. And I'll have this uploaded and I'll open the test for you guys. Again, it's 32 or 34 questions worth 50 points. If you haven't noticed, I like short answer. I know you hate it, but I like it. It makes it harder for me to grade, but I do like them. And that's it. Does anyone have any questions before we sign off? And I will open up the test for you.
I have kind of just like a random question. Do you know if melatonin, because I know that it is over the counter and they even make it in like gummies and kids gummies, but like, does melatonin also have an effect on your dopamine?
That's a question. It does not, and it doesn't, and that's because it doesn't have anything to do with the reward pathway. That's an excellent question, and the way that we know that is that we slid someone into a PET scan or a functional MRI, and we can give them melatonin, and it won't light up in the dopamine region in the reward pathway. So dopamine is completely safe. Melatonin is completely safe, and the gummies are delicious. Yeah, my dog ate a whole thing of it and then threw it up all over my floor. She can open pill bottles. Yeah, she's watching me too, so I'm scared of her. Okay, so that's a great question. And I think that's all I had. You guys are going to take the test. There was something about the test I wanted to give you. Like, is there a hint? There was something. I'm not worried. There's a couple questions you're going to see on there that you haven't seen before that are NCLEX style questions. I gave you the hints on your, that thing that I gave you for help. So just hopefully you looked at that. And one last reminder, you guys know you have that extra credit, right? So if you end up with on your let's just pretend on this test you got like a 42, which is not bad, but to me, like, I'm like, oh my God, I better get a 48 at least out of 50, right? Remember, you have those extra credit from Nurse Blake, and you're still I'm not done with them. You still will get them. I'm still gonna continue to add them. So you'll have a little extra credit here and there, okay? Just as a reminder. Okay, all right, you ready? Okay. You're all gonna do well. Let me know if you need me before then. I'll be in contact about the Skittles clinicals, and I will open the test for you now, and have a great weekend. You're welcome.
Wait, I have a question. So you know how we already went over that practice NCLEX question. I hadn't turned in the thing yet because it says due Monday by 11:59 p.m. Do we still need to submit that because we already went over the question?
What assignment was that?
It says one practice NCLEX question.
Oh,
It's for 0 points.
okay, I was gonna say, I was trying to remember, is there points, and I'll just say I'll remember your name. No, you don't need to. You're good.
Okay, thank you.
You're welcome. But next time, do it, okay? Or you're in trouble. Was that scary? It's not, right? Yeah, for this time, that's fine. You guys are all doing really well with your assignments and being on time, so Priapism. Is that
But she was asking because it's not due till Monday.
Oh, I thought you meant, oh God, I'm yelling at you for no reason. No, it's fine. It's fine. You guys don't have to do it. None of you, you know what? None of you have to do it. Not just Yuki. I won't play favorites. All right. So you don't need to do that question. You understand it. You're going to do fabulous on your test. I'll get it graded as fast as possible. And if you need me, I'm here. Okay? And good job today, guys. I'm remembering and regurgitating the information. It will, trust me, it will, when you get to clinical, especially if you're there, hopefully you're noticing that. So have a fabulous day. Okay. All right. Thank you. Thank you so much. Have a good one. All right. Bye.